Okay, so today we're going to be talking about medical social work. For background, I am a medical social worker myself. I'm actually coming off of an overnight shift from last night, so definitely feel like I'm fresh off of a shift where I experienced some helpful things that we can talk about today, and it's fresh in my mind. Um, the learning objectives for the course today. By the end of this course, my goal is for you to be able to describe the unique role in of medical social workers across our healthcare systems, to be able to differentiate medical social work from traditional outpatient psychotherapy. There are some crossovers, but they're two very different roles as well. We're going to talk about that. We are going to talk about how to apply efficient psychosocial assessments and crisis intervention strategies in fast-paced medical environments. If you have been in the healthcare system as an employee or as a patient, you can definitely see that in the world today, it's a very fast-paced environment, and the work that we have to do definitely shows. So we'll go over that and then also identify best practices for discharge planning, interdisciplinary collabs, documentation, and ethical decision making. And I know that sounds like a lot of big words, big conversations, but we're going to dive deeper into each of those because if you don't work in the field, something like interdisciplinary collabs might not mean anything to you. So that's definitely something. Those are some important things that we're going to go over today. Oh, sorry about that. Here we go. So before we get into that, what makes me qualified to talk about this topic? I am an LCSW. I went to Case Western where I earned my Master of Science in Social Administration in 2022 is when I graduated. So I was there over COVID, which was an interesting experience. But over the past 4 years now, I've worked in a few different settings. So I was first at the Cleveland Clinic in an outpatient pediatric behavioral health department where I learned a lot, but I also quickly learned that that was not a field for me, meaning behavioral health. There are people who thrive in that environment. And like I said, learned a lot, had a lot of great mentors, and it was a great first job out of grad school. But I learned that behavioral health was not the field that I wanted to be in. So I pivoted and I went to a different hospital. If you're familiar with the Cleveland area, I went to Metro Health, which is the county hospital in Cleveland. And I started working in adult inpatient medicine, which is very different from outpatient pediatric behavioral health. And I started there on the medical ICU, but during my time there, I worked on the medical ICU, the cardiac ICU, the step-down unit, and then some general medicine floors. If you've ever worked in a hospital, you know that there's also a lot of shifting around in the hospital. You could cover floors when people are out sick or on vacation or on maternity leave. So I also got to experience some time while they weren't my units on some trauma units and in the emergency room. And while I was doing that, I learned that something about myself as a social worker is that I like the fast-paced environments. I like the crisis intervention. I like the first response. And while you get a little bit of that on ICUs, I realized that that was like really my strength and I was really thriving while that was going on in the emergency room. So I'm actually from Chicago, and my husband and I made the decision to move back to Chicago last year. So I unfortunately had to leave that inpatient job, even though I loved it. But I knew that when I was finding a job in Chicago, I wanted to find a job in the emergency department. So I now work in a pediatric emergency department. I work nights, so I work three 12-hour shifts, which I also think is interesting as a social worker. I feel like it's important to talk about like the different shifts and the different jobs that are out there that there's not only Monday through Friday, 9 to 5. So I feel like I have kind of a unique schedule where I work those 3 12s overnight. And it's a pediatric emergency room, so I help children and families navigate crisis. I do a lot of work with children who are presenting due to physical or sexual abuse, and I address the outcome. I address the psychosocial needs that impact the health outcomes. So, what is medical social work? Again, this isn't something that if you haven't yourself, like I said, been working in the healthcare system or a frequent patient in the healthcare system, you might not have come across medical social work before. So, medical social work is a specialized field of social work practiced within healthcare settings. So, professionals in this role help patients and their families navigate emotional, financial, and social complexities of illnesses. Some of this is a list of some of the places where you might find a medical social worker, but it's definitely not exhausted. So the emergency room, inpatient units, like I was talking about my experience before, there's a variety of different inpatient units. So there's neurology, there's cardiology, there's oncology, there's psychology, there's a psych unit. So there's a lot of different specialties within that. Pediatrics, outpatient oncology or inpatient oncology, hospice and palliative care, dialysis, outpatient specialty clinics, inpatient psychiatry, home health care. Like I said, there's a variety of these places. So, our goal as medical social workers are to bridge the gap between medical treatment and psychosocial functioning. Um, so the role specifically of a hospital social worker, and this is going to vary from hospital to hospital, from clinic to clinic. That's definitely something that I've learned from going to three different hospitals now, is that the responsibilities that are expected of a social worker are going to be different anywhere that you go. So there's definitely a lot of common ground, but the same way as if you are working at a nonprofit or if you are working in independent practice providing therapy, every place is going to do things a little bit differently. So, you just kind of have to learn from your peers at that specific hospital. But some of the daily responsibilities that you might see are crisis assessments. If someone is coming in crisis, that might be something that you're addressing. Capacity concerns. So if someone is in a mental health crisis, if we have an older patient and they are experiencing some kind of dementia or Alzheimer's, if you have someone with a developmental delay, these are times when you might be completing a capacity assessment, and working with other disciplines to figure out if this person has capacity to make their own decisions. Family meetings. There's a lot of family meetings that take place in healthcare for a variety of reasons. In the chat, I'm interested to hear what are some of the reasons that you guys think that we might have a family meeting in a hospital setting on any unit. What are some of these reasons? And there's no wrong answers because I've done them for everything. Disagreement about goals of care, end of life care. Yeah. A lot of that would be death. A lot of that kind of falls under the same umbrella where we're doing a lot of meetings for with family. A lot of people have a lot of high emotions, understandably so, when someone is coming to the end of their life. Sometimes that patient doesn't have capacity and sometimes they do. And there's a balance of sister, brother, mom, dad, cousins, everyone wanting something else. And there's definitely some legalities that come into that, but our goal as a social worker would be to mediate that conversation and make sure everyone feels heard, especially the patient. You are advocating for the patient in those situations. So that's a really good example. I'm seeing like continuation of care, community resources, that kind of thing. We're definitely going to get a little bit into that as well because a lot of those family meetings are around discharge planning. And there are a lot of options when you get into discharge planning. So we're going to talk a little bit about that going forward as well. Um, so another responsibility, something that I see in my job every day, unfortunately, is abuse investigations. So I get paged anytime a child comes into the emergency room with any kind of physical or sexual abuse concerns. And I help facilitate that investigation with either a doctor or a nurse practitioner, pending what the exact situation is. But that's definitely, unfortunately, a part of my daily tasks at work. Addressing homelessness is definitely a big thing in the healthcare system. Transportation barriers can be a huge issue when trying to make sure that someone is healthy and making sure that they have access to the care that they need. Financial concerns. Unfortunately, it is expensive to be sick in the country that we live in. So that's something we address. Guardianship issues, again, that goes into capacity concerns. Substance use is something that a lot of us see working in healthcare because there are so many comorbidities with addiction, end of life planning, and discharge planning, which, like I said, there's a lot behind discharge planning, which is something that I have learned working in adult healthcare specifically. So we're going to talk a little bit more about that in the future. So, what is the difference between medical social work and outpatient therapy? Hospital social work is a lot of short-term care. If you are working on a unit like an ICU, so whether that be a cardiology ICU or a neurology ICU, you might be seeing the patient for a longer period of time than, let's say, they're admitted to a general medicine floor for a day or two. So it might start to feel like long-term care, but the goal is not to have a long-term relationship with that patient. Not that you don't want to see them again, but you kind of don't want to see them again because if you don't see them again, that means that they're healthy, right? So the goal is a short-term relationship with them to make sure that they are set up for success when they leave the hospital. Where outpatient therapy, you're definitely building that long-term relationship with them, and there's not really the end goal is whatever you put in your treatment plan, but it's typically not a short-term plan. Um, Hospital social work is very solution focused. So a lot of the time that we are paged or consulted when in the hospital is because there is a problem. So we are there to help find solutions to those problems, whether it be transportation or homelessness or substance abuse resources. We are trying to find a solution to that patient's problem that is making it difficult for them to have a safe discharge plan or feel like they are supported in the hospital. Outpatient therapy is very insight oriented, so you're kind of going off of what the patient themselves really wants. Hospital social work, a lot of the time, is crisis stabilization. Not always, but a lot of the time it is crisis stabilization. You are getting called in when there is a big problem at hand. You will probably see this more often in like an emergency room setting, where you all of a sudden get a call from a doctor or a nurse and they're freaking out and they need social work to come in and neutralize the situation. I know that that's when I'm consulted a lot of the time, where outpatient therapy is ongoing treatment. It's kind of more of like a steady stream rather than big ups and downs. Um, Hospital social work. Oh, Megan, did you mean to raise your hand?
Yes, I just have a question that I think could be helpful for some people here that maybe are not super embedded in the hospital setting. Is there any scenario or role where it's a mix of the hospital social work and outpatient? Because I do know some programs have an outpatient component or they're housed physically in the hospital, but it's not necessarily a medical unit.
Yes. So we do a lot of a lot of what we are doing in discharging patients is connecting them with outpatient resources so they feel like they're supported um in the community. So if you have someone who is on an inpatient psych unit, you're not going to just discharge them to the community without any support, right? That person was in a to get admitted into an inpatient psych unit, they had a lot going on. So when you are planning their discharge, you would really want to make sure that they are connected with someone maybe like who is an outpatient therapy provider or an intensive outpatient program where they're going multiple times a week for long periods of time. So there's definitely a lot of overlap where it's helpful to know the resources in your community when you're planning a discharge. Or it roles reverse that outpatient program, if they see someone who's really in crisis and they feel like they need some more support and they feel like they need an inpatient setting, they know that they can then refer the patient to this inpatient setting. And that goes not just with psych issues, that can also go for um, things like if someone has like cardiac issues. There a lot of the times there's a lot of overlap between those like outpatient doctors and inpatient doctors, and then also the social workers who are communicating back and forth like what they can do to because a lot of those people are followed by outpatient providers for a long time. They have these like chronic issues. So when they get admitted to the hospital, their outpatient providers are notified and there's that communication. So yeah, that was a good question. Thank you, Megan. Um, and then another, what I think is probably one of the biggest differences as well, and something that I actually love about inpatient social work is that it's very interdisciplinary. So what that means is that you're really never working by yourself. I don't think I have ever gotten through a shift where I haven't talked to other disciplines, and that is because everyone really relies on one another. And That means that I am talking to nurses, doctors, physical therapists, occupational therapists, speech therapists. The list goes on to make sure that this patient is getting the best all-around care. So a lot of the times that's discharge planning, but then it's also just like plan of care. That's making sure that everyone's on the same page. You'll hear like interdisciplinary rounds is a big thing when you're working on an inpatient hospital social work. When you're working in an inpatient hospital social work position, you'll do interdisciplinary rounds in the morning so that everyone gets on the same page of where everyone is at in their treatment because everyone has their specific thing that they're focusing on. Where outpatient therapy is a little bit more of independent practice. Okay. So something I think a lot of us learned about in grad school probably is psychosocial assessments. And a psychosocial assessment helps identify factors that may impact a patient's medical care, recovery, safety, and discharge planning. So these are just some examples that of questions that might come up in a psychosocial assessment. So again, not all of these questions, all of these topics are going to be appropriate for every assessment that you do, but all of these will come up at some point with different patients. So, like we talked about earlier, a living situation, you want to know what that person's home environment is like, what their housing stability is like, what their accessibility and safety concerns are in their home. If someone is living in a decrepit home, which is something that I've seen multiple times, it's not safe for them to discharge back there. So that's when social work would come in and try and work to find a solution so that this person has a safe discharge plan. We want to learn about their support system, and with that, we want to learn about their strengths, and their protective factors. So it is always it is always helpful to have someone who has family and friends at home who are able to support them and able to step in and assist if that is needed when they're discharging from the hospital. Their mental health. What is their mental health history? Where are they currently at? Even if they don't have a mental health history, how are they doing with getting admitted to the hospital with maybe they have a new diagnosis? What is going on with them in that situation? Substance use. This is something that a lot of us have seen in our practices, and there's a lot of comorbidities that come with substance use. So, do they have any alcohol or drug use history? Have they currently or previously been in treatment? Are they ready for a change? I have met with countless people who they're aware that they have a substance use problem. They know that if they don't stop, their health is going to be impacted, but they are not ready for a change. Our job is not to stand there and judge them, but our job is to support them if they're ready for that change. Financial and insurance needs. So we help with insurance coverage, with medication affordability, with financial concerns impacting care. Um, I'm curious in the chat how I know that not all of us are medical social workers, but I think this applies to any discipline of social work that you could be in. What are some examples of times that financial problems have come into play to limiting a patient to getting what they need? So there's been a family that really needs this one thing that will help them, and money comes into play, and we unfortunately can't always solve those problems. Insurance is a really big one. Yeah. Medication. Yeah. So a lot of the times people will not have the medications that they need in order to stay out of the hospital. So if someone needs this heart medication and they can't afford it, then they're just going to keep ending up in the hospital because they're not going to be taking it, and then they're sick enough to get admitted. Um, Someone said not having a car. That's a really big one as well because a lot of people with these chronic health issues can't get to their appointments. They can't get to the pharmacy to pick up their medication. They can't get to therapy, physical and occupational therapy. Or if you think about someone like with dialysis, someone who's getting dialysis has to go 2 or 3 times a week. If they can't get there, they're going to get really sick and they're going to need to get admitted to the hospital. Um, Getting home attendance or yeah, that's a really good one, like home health care or um, something like a skilled nursing facility or something like that. There's this weird middle ground that I think a lot of us have seen in America where you have too much money to qualify for Medicaid, but you don't have enough money to pay for the care that you need. So that's definitely something that we come across a lot. Yeah, lack of food. all of these things. Unfortunately, we all have a lot of examples. DME is a really good one. So for those of you who don't know what DME is, that's things at home like bedside commodes or a hospital bed or things like a cane or a walker. So like those accessibility things at home. Yeah, these are all really great examples. Thank you all for sharing. The next would be safety concerns. So, concerns for abuse or neglect. I think a lot of us think of children when we think of that, and that's a very important aspect of when abuse and neglect concerns would come into play. However, it's also important to think about that when we are working with adults. Domestic violence is a big concern. I would add on to that also human trafficking is something that has been brought to my attention in medical social work frequently. Self-neglect, so someone who is either unable to take care of themselves, or not taking care of themselves, whether that be because of a physical ailment, whether that be because of a mental health issue, that comes into play a lot when you see some people coming into the hospital. They can be in pretty rough shape. I see in the chat someone said APS is often an issue as well. So APS is Adult Protective Services, and that's someone that you can reach out to when you do see these issues. And I see some people saying APS is an issue, and there's always complexities to all of this. You can refer out as much as you want, but unfortunately, those resources can only do as much as what they're able to. So that means like if they get a referral, but someone's not letting them in their house, unfortunately, that's kind of where they draw the line. But that's a little bit of a gray area. Strengths and protective factors. So, like I said earlier, you also want to talk about the good things that they have going for them. Are they resilient? Resiliency makes a huge difference in a person's healthcare. If they are motivated to get better, if they're motivated to put the work into their therapies, their physical and occupational therapies to get better, if they have a positive mindset, that's going to get them along a lot further than if someone's just giving up. So that's always a strength. And then also family or caregiver involvement is very important as well. Okay. So when I'm thinking about a psychosocial assessment, I always like to think about beyond the diagnosis. So we were giving some examples earlier. If someone comes in with a hip fracture, we'll assume that this is an elderly person because that is the typical demographic of someone who's getting a hip fracture. This person lives alone, has multiple stairs to enter the home, and limited caregiver support. Um, What are some interventions? I know that we have some of the interventions on the screen. What do you guys think are some of the biggest interventions that would be helpful for this patient? Yeah, so I see a PT evaluation first. PT, if you haven't noticed, in healthcare, we do a lot of abbreviations. I always catch myself doing this when I'm typing, because when I'm putting in a medical note, there's so many abbreviations I use that I'm like, if someone doesn't work in healthcare, they probably don't think that I'm typing in English. But PT, yes, PT, OT. PT is physical therapy, occupational therapy. So that would be first. When you're in those interdisciplinary rounds, you can say to the doctor, hey, can you please place a PT, OT referral for this patient? I think that they are going to need some sort of referral when we're finished here. So they can see them, and if they recommend a skilled nursing facility referral, then you speak with the family about putting in a skilled nursing facility referral, and we'll talk a little bit about that in a little bit also. If they have family, if they ask for family to be involved, then you can have a family meeting about that to plan their rehab. So those were all really good answers as well. For a new cancer diagnosis, this could be very anxiety inducing. There is a limited understanding of a diagnosis when a patient first gets it, and a lot of the times there can be financial concerns. Like we said earlier, it's unfortunately very expensive to be sick in this country. So you can provide some emotional support. You can refer to oncology resources, which will differ from community to community. Support them with giving them some financial assistance, information on financial assistance, and if necessary, if appropriate, if they ask you for it, advanced care planning. Someone with diabetes with recurrent DKA. So they might have difficulty affording insulin, and inconsistent access to food. Food is a big one when it comes to something like diabetes. So supporting them with food resources, with diabetes education. I think every hospital I've worked in has had a diabetes educator, which is a big deal. But a lot of people also, I've met with countless patients who have had issues paying for their diabetes medication, for their insulin. And that's really unfortunate to see because it's something that they need to survive. So trying to help them with those resources. COPD ex exacerbation. COPD is a lung disease. So this is when you're speaking to them, you find that this person has continued to smoke, lives with smokers, and has limited transportation to appointments. Coming back to the transportation again. So you can provide them with some resources to help them quit smoking. You can ask for a referral to a pulmonary rehabilitation clinic so they can see someone outpatient as well to try and limit those admissions to the hospital. And then transportation assistance as well. So, crisis intervention versus ongoing treatment. So, a lot of the time, what we're doing in the hospital, like we talked about earlier, is crisis intervention. So we are getting called in when there is a big situation going on, and it is our job to stabilize that situation. So we can get paged to help stabilize an argument with a family, or if there's a safety concern, if there is a visitor that is causing a safety threat to staff or another patient, or if a patient is causing a safety concern. We can step in to help with emotional regulation if someone has just received some bad news and they need some help processing that. You can try and use your social work skills to help regulate that emotion. We also often get paged, at least in my experience, and I think a lot of people that I speak to that work in medical social work, we get paged for some things that might not be appropriate. Or I see someone right now saying that they get paged sometimes saying he's medically ready for discharge, he has to go immediately in that moment. What are some examples of things that you guys have been paged for where you're like, oh, I don't know if this is a social work concern? A parent being on the phone. Yeah, that's a good one. I can tell you I was paged recently because a parent had gotten a parking ticket and they needed help coping with that. So finding a boyfriend housing, not knowing who the person lives with. Right. I think part of learning your place in the hospital when you go into medical social work is learning when to give pushback as well. I think a lot of the times in these environments, a lot of healthcare providers think, oh, just refer that to social work. Any kind of social issue, refer that to social work. And I think a big thing is learning when you need to put your foot down and say, this isn't appropriate. This is not something that social work needs to be paged for. There's a lot of the time when you do need to be paged, but there's also times where it's not an appropriate referral, and it is okay for you to appropriately and professionally share that with them. Um, Megan said medical providers just being uncomfortable with certain conversations and calling social workers as default. Yes, that happens a lot as well. And it sounds like there's some people who are agreeing with them. You will learn that there are a lot of people who are uncomfortable with um, appropriate confrontation, right? Confrontation might not always be fun, but unfortunately, sometimes it's what has to happen, and everyone is capable of it. Um, And then you get DCFS concerns, and no nurses are the ones that call. Yeah, that's something that we work with a lot at our hospital as well, where if another staff member witnesses something or gets a disclosure that requires a DCFS referral, they will call social work and say, can you call DCFS about this? And I will more than likely push back and say, if you got the disclosure, if you witnessed this, you need to be the one that calls DCFS because they are going to want that referral from someone who witnessed it firsthand. You can always offer to come and support them and sit with them while they make that referral, but in those situations, it would be appropriate to push back. So yeah, everyone is a mandated reporter, that's true. And boundaries are very necessary. Boundaries, I think, are the name of the game in this conversation. So, those are all really good answers. And then some useful interventions. We can go back to our days of getting our master's in social work. validation, psychoeducation, safety planning, grounding, motivational interviewing, solution-focused questions. I think a lot of us probably, we learned, like I said, we learned all of these in grad school, but we probably do these things without even realizing we're doing them right now. I know I use motivational interviewing all the time when I'm talking with families, and I don't even realize I'm doing it until after the fact, or I'm like, oh, I actually did learn that, and that was helpful. So then we go on to mandated reporting. So child abuse and neglect assessment and mandated reporting. I know that we also have certain things that we need to report to Adult Protective Services where we discussed that we discussed earlier. However, we are going to be focusing for the purpose of this part of the conversation on child abuse and neglect. So our role in these assessments and mandatory reporting is to assess family dynamics and psychosocial factors, gather collateral information, evaluate safety concerns, support the children and caregivers, collaborate with the healthcare team, and report reasonable suspicion when required by law. So when our mandated reporter title would come into play. The biggest thing that I think we should take away from this is our responsibility is to report these concerns and not investigate them. So I know that for myself, like I said, I do a lot of this in my job. When you are working on a suspected child abuse case, we call them in my hospital non-accidental traumas. If you are working on an NAT, a non-accidental trauma, it feels almost like you might be investigating because you go in and you're asking everything about that family's background, all of their demographics, all of their childcare. You're asking the nitty-gritty details, but you are asking those questions so you can document them in this child's chart. You personally are not investigating. The correct authorities will be investigating afterwards if necessary. So there's different types of child maltreatment. So we have physical abuse. This again is not an exhausted list of examples, but some examples of physical abuse would be unexplained injuries. If someone comes in and there is a skull fracture and they're like, I don't know how my baby got this, and the baby's 6 months old or 6 weeks old and they can't move around by themselves yet, that's a concerning unexplained injury. Um, Again, injuries inconsistent with developmental level. So if they're not moving around by themselves, how did they get this fracture? Delayed medical care, if this kid is seriously hurt and they're not coming to the hospital in an appropriate amount of time, that's a concern as well. Neglect, so inadequate supervision, if something happens while the child is not being watched appropriately. Food insecurity. I really want to put a disclaimer in there that being poor is not a crime, but not providing your children with what they need to thrive and to live is a concern. So, like if someone is clearly putting in the work to try and get those resources to make sure that their children are fed, that's one thing. But if a child is just outright being neglected, that's a concern. Megan, what is your question?
Yeah, I just wanted, I think that this would be a good time to kind of bring this into the group in the chat. I know that there's a lot of talk right now around and it's not our jobs unless we are working for CPS or CFSA to obviously investigate, but how do we, so say someone is having difficulty with resources, or having difficulty with hygiene, how can we provide wraparound services before just automatically jumping to make a call in the medical setting, given that they're not with you very long for you to collect a ton of information?
Yeah. While people are typing out their answers, I feel like I can speak from my experience. Um, Something that we try and do is if we get consulted for food insecurity or we can get consulted for like infant supplies insecurity, we'll go and talk to them, give them resources in their community. We'll give them some stuff to get started, some like non-perishables or some infant supplies like diapers, formula, wipes. Another thing that, at least in Illinois, which is the state that I'm working in, you can call DCFS and ask for resources. That doesn't mean that you're in trouble. That means you're doing the right thing and asking for resources for your family. So those are just two examples that for first come to mind. And that's not you making a DCFS report. That's calling and saying, "Hey, I'm looking for some resources," and they actually have a lot of great resources. So yeah. Um, I'm just reading some of the other chat. Helping with connections to community, resources that can help the family. Yeah. So a lot of that, because you, like I said, we can give them some starter stuff, a few things, but that's not going to last them forever, right? So connecting them with places in their community, whether that be food banks or churches or whatever these places, diaper drives, whatever these places are that have some extra resources. Um, Search and connect to clients' resources. Yeah. And you'll start to, once you start doing this, you'll start to know the different communities in your resource. Yeah, a lot of provide resources in the community. And I would agree with that. Um, okay. And then another type of child maltreatment, unfortunately, sexual abuse. Sometimes that this would come up, again, not an exhausted list, but times we would be concerned if there's a disclosure by a child, we always believe the child. We don't question that. Children don't make things like that up. So a disclosure by a child concerning sexual behaviors that are not appropriate for that child's development, or an STI or pregnancy in a child. So here is a case example that we can talk about. So we have a 3-year-old who presents to the emergency room with a spiral fracture of the humerus. The orthopedic surgeon states the injury is not consistent with the reported mechanism. So what that means is that the family would come in and say, my child got this by playing soccer in the backyard and tripping over the ball. So the orthopedic surgeon would come in, look at the injury, and say, "That's not how this kind of fracture happens. This fracture happens by like a blunt hit injury, right?" So that's what I mean by inconsistent with the reported mechanism. So again, what we would be doing is completing a focused psychosocial assessment, collaborating with the interdisciplinary team. Again, we talked about the interdisciplinary team earlier. So, with the nurses, the doctors, the APNs, the CNAs, everyone who is touching this patient, collaborating with them, following mandatory reporting requirements, and documenting objectively. When you are going and talking to a family in this situation, when you're doing a psychosocial assessment, what are some of the questions you feel like you would be asking this patient or asking this family? Yes, noting that language is not a barrier. All hospitals should have interpretation services, so making sure that the family understands what you're speaking to them about is a very important conversation. Any issues at home? Yes, so asking about any issues at home. So when it comes to psychosocial assessment in this situation, I would start with the basics. Yeah, who watches the children? That was going to be the next thing that I was going to talk about. Are there any other children in the home? So a lot of what we talk about at first when we don't even talk about the accident yet, we get the background on the family. So we talk about things like who's living in the home with you? Does mom work? Does dad work? Who watches the child and what is the schedule around that? What are your disciplinary practices in the home? Things like that. And then once you get some more of that background information, you can start talking about what actually happened that day that brought them in. Yeah, any substance use issues. So any kind of risk factors, actually. So I'll always ask if there has ever been any DCFS involvement, if there's been any law enforcement involvement with the child or also with the parent. It's actually a proven fact that it's a risk factor if the parent had had DCFS involvement when they were a child as well. So that's something that we ask about. Any mental health issues, any domestic violence in the home, what are their support systems, that kind of thing. So again, completing that focused psychosocial assessment, gathering information, a timeline. I write very detailed notes about the injury and the timeline. I always tell families when they're telling me the story, I want to be able to close my eyes and picture exactly what's going on. So I want to know what the material, if there was a skull fracture, let's say. We get a lot of the times, we do assessments for anytime a child under the age of 1 has a skull fracture. So even if we don't think that it was non-accidental trauma, it meets the algorithm in our hospital. So just using that as an example, I'll ask them if the baby rolled off the bed and has a skull fracture. I'll ask them how high was the bed, what material was the floor, what position was the baby in when you went and grabbed them off the floor, that kind of thing. Um, You'll collaborate with the interdisciplinary teams, like I said, with the physician, the nurses, and the child protection team. Once you make that referral out, share any findings that you have, and then participate in developing a coordinated plan of care. So sometimes DCFS will be involved in that, sometimes they won't. If they are, then they will probably take the lead on what a discharge plan will look like. Follow mandatory reporting requirements. So report concerns when there's a reasonable suspicion of abuse or neglect. Follow your state laws and hospital policies. So make sure that you are very educated on that. And remember that you are reporting suspicion and not proof. You are reporting things that you have valid suspicion on. Um, and then document objectively. So record factual observations and direct quotes, document interventions, consultations, and reports made, and avoid opinions, assumptions, or conclusions. I will read back if I'm writing down what a parent told me happened that day. I will read it back to them to make sure that I am putting it in their words because I don't want to put words in their mouth. I don't want to be accidentally putting assumptions into the conversation. And your opinion does not have a place in a medical chart. So, unless you are a professional who is consulted to put your opinion, your professional opinion, into this chart, we are not putting our opinions in. So, again, one more time. Medical social workers do not determine whether abuse occurred. Our role is to assess psychosocial concerns, collaborate with the healthcare team, document objectively, and ensure concerns are reported according to your state law. Um, let's see. Jessica said once had a toddler and it was their third accidental skull fracture, but it wasn't shared until I read previous medical records. Yeah, so sometimes we are doing a little bit of digging on our own. A lot of the times when I get referred, actually every time I get a referral, I'll always go and see if they have any previous social work notes, or if they've ever met with our child abuse pediatric team previously, just to make sure I'm up to date on whatever is going on in that person's chart. Genetic conditions is another thing that comes up. Yeah, and that's why we have these doctors that are amazing and they know what they're doing because sometimes you can have a situation where a child has these like deep bruises and it's not because of non-accidental trauma, it's because of a blood disorder or something like that. So it is important to rule out those genetic disorders or blood disorders. I don't know if anyone watched The Pit last season, season two, but there was a situation where a patient had ITP, which is a blood cell count disorder, and she got these really deep bruises, and they were being very accusatory of the dad abusing her, and it turned out that she had this disease, ITP. So again, it's not our job as the social workers to come up with those diagnoses, but that is something that doctors will go through. Okay. Discharge planning. So just discharge planning, kind of going back to adults in my experience. And again, everyone has different experiences. From what I've seen, a lot more in pediatric settings, case managers will take over discharge planning, but I've seen a lot of adults in inpatient units for adults, social workers will help with it. So discharge planning is a collaborative process that ensures patients transition safely from the hospital to the next level of care while minimizing barriers to recovery and reducing the risk of readmission. So our goal is to make sure that they safely get from our hospital to the next place that they're going, and they have a good plan in place for that. So some common discharge destinations, we've talked a little bit about some of those as well. So if they're going home, they're independent. Some people can go home with home health care services, a skilled nursing facility, an inpatient rehab facility, a long-term acute care hospital, hospice or palliative care. Those are two different things, just to be clear. And then assisted living or memory care. So discharge planning, you will often hear begins at admission and not at discharge. You want to be proactive about this, not reactive. So as soon as you get that alert from physical therapy or occupational therapy that a patient's going to need a skilled nursing facility, starting to work on that because as you'll see in our next conversation, insurance is going to get involved and that can take a long time these days. So here's an example. We have an 81-year-old male who was admitted after a hip fracture that required surgical repair. He is medically stable after surgery. He lives alone in a two-story home. He requires assistance with walking, transfers, dressing, and bathing, and he has limited support nearby, family support nearby. Um, Social work came in and evaluated his home situation, his home environment and support system, collaborated with physical therapy, occupational therapy, nursing, and the physician, and identified the patient is not safe to return home independently. What would our next steps be? A skilled nursing facility referral, placement, yeah, rehab. Determine where they're going if they're not home. Yeah. So all of these, the basic point is they have to go somewhere, right? They can't go home. They're not safe. So that's where social worker would come in. So a medical social worker would go and talk with this person, explain their recommendation for short-term rehab in a skilled nursing facility. They might know what that is. This might not be their first rodeo, or they might have a lot of questions about what a skilled nursing facility is. So we're addressing those concerns about leaving his home temporarily. We would review Medicare coverage and insurance benefits, and then provide a list of preferred skilled nursing facilities that are within his insurance. And then we coordinate insurance authorization, facility acceptance, and transportation. Now you know why I said earlier that this can take a long time. And then we, in this situation, could communicate with the patient's daughter to ensure she understands and supports the discharge plan. This would, to be clear, be with the approval of the patient. We're not calling people and disclosing medical information to people unless the patient is asking us to do so. And the outcome is Mr. Johnson is discharged to a skilled nursing facility for short-term rehab. And this just is a great example of the interdisciplinary collaboration. None of that could happen without all of us discipline working together in our disciplines. So physicians, nurses, case managers, all of us come together to support a safe discharge plan, and having really great communication is vital in these situations. Documentation best practices. So, documentation should be objective, relevant, concise, and legally defensible. So, again, we're not putting opinions in there. We are putting in the reason for the consult, the assessment, interventions, resources provided, disposition, follow-up plan. And again, I know I keep saying this, but it's because it's important. We're avoiding subjective statements. So here's a really great example of a medical social work progress note, and I tried to include, like I said earlier, some of those abbreviations that you'll see. And if you're ever in a medical social work position, you'll get used to them. So I know that when you see them, it's like a little bit confusing, but um, this is an example of one. Physical therapy and occupational therapy continue to recommend skilled nursing facility placement due to the patient's need for assistance with mobility and activities of daily living. So that's why you're getting involved. You just stated right there why you were consulted. Social work met with patient at bedside to discuss discharge planning recommendations. Patient remains agreeable to short-term SNF placement following hospitalization. Reviewed facility options with placement. Patient identified facility A and facility B as preferred choices. So you put in there where you gave him his right to make a decision. Social work placed referrals to both facilities, and facility A accepted the patient pending insurance authorization. Authorization was initiated today. Patient's daughter was updated. So you're also putting in there that you want people to be any discipline to be able to go in, read this note, and know where you are in the discharge planning is the goal of this medical note. And then you're just letting them know you'll continue to monitor insurance authorization and what you're going to do after you do get that. All right, I don't want to run out of time, but some common ethical dilemmas are respecting patient autonomy while promoting safety. So, like I mentioned in this last case study, when you had this patient who was discharging somewhere, you want to make sure you're getting their approval before releasing any of their medical information to any other family members. Even if you don't think it's a big deal, you want to get that approval from them. Determining decision-making capacity, we talked about earlier, managing disagreements between patients, families, and the healthcare team, navigating confidentiality and information sharing that kind of goes into what we just talked about as well. Addressing limited resources and barriers to care, which is a thing that we discussed earlier as well. Things like food and infant supplies and clothing. We want to make sure that people have access to that, and that there's no ethical dilemmas within that. responding to suspected abuse or neglect, and managing moral distress and professional boundaries. Um, and then always applying the NASW Code of Ethics. So when faced with an ethical dilemma, we identify the ethical issue, gather relevant information, and consult the NASW Code of Ethics because all of us are social workers. Consider the patient's values and wishes and document your own decision-making process. For the sake of time, I am gonna skip over this case study because it's a little bit long. Um, but I think you guys all have a copy of this. So if you ever want to go back and go through an example of that case study, feel free. I feel like that was a little bit of a more detailed one, so it could be helpful. So, in conclusion, medical social workers are an essential member of the healthcare team. I always say to my managers and my directors when I'm advocating for myself in in the healthcare system, meaning as a provider, not as a patient, we're essential. They would not be able to function without us. Oh yes, Megan made a good point. I'm thinking of myself because I'm a social worker, but your profession's code of ethics. So if you're a counselor, if you're a licensed marriage and family therapist, refer to your code of ethics. Thank you, Megan. Um, so yes, we are essential. The hospital couldn't run without us. So remember that you are important in these situations and that you have just as much of a right to be there as a doctor, as a nurse. Medical stability does not always mean discharge readiness. As we see, there's a lot of comorbidities that are happening, and there's some social situations that could come into play. That means that just because this person's medically stable doesn't mean that they can discharge. Um, and then effective medical social work requires a lot of different things coming together, right? It's not just one aspect, there's a lot of key aspects going on. Thorough objective documentation is important. I always say that if you didn't document it, it didn't happen. So making sure thorough objective documentation is there, it supports continuity of care and it makes the communication between social work and the rest of the healthcare team helpful. And every interaction is an opportunity to improve patient outcomes by addressing the whole person and not just the medical diagnosis. Most importantly, we are working with people, and people have feelings, and people have rights and emotions. And I just want people to think about that when they are speaking to a patient and not just thinking of it as a job that they're trying to get through the day. Okay. So I will hand it back over to Bonnie, but thank you guys for involving yourselves in the conversation, for participating in the chat. It's really helpful to hear other people's experiences and what they see in their communities.
I hope you enjoyed this continuing education course from Agents of Change. Want to earn your CE credits for this course? Visit agentsofchangetraining.com or click the link in the description to purchase the course and earn your CE certificate. If you're looking for more CEs, check out our unlimited plan. You get unlimited access to more than 200 ASWB and NBCC approved continuing education courses and more than 20 live events each year for one low annual fee. We're always adding new and exciting courses. Check it out at agentsofchangetraining.com.